So what I'm going to be talking about today is the Belin ABCD staging and progression display, particularly the latest iteration of the display, which includes the post-crosslinking data. So the first thing I always get asked when people go, why did you develop a progression display, is, well, can't I just follow patients with the final D from the bad display? Or can't we just follow the parameters from the ABCD staging or classification? And you have to remember that the Belin-Ambrosia display was designed specifically to screen refractive surgical patients. It was designed to separate normal from abnormal. Though it's very useful in keratoconus diagnosis and detection, it is not necessarily specific for ectatic disease. If you look at the picture on your lower left, that's post-refractive. It's not keratoconus, but obviously it's not normal, so it's going to have an abnormal final D. The upper right is hyperopic LASIK. Looks very much like on the anterior surface like ectatic disease, but again, it should have an abnormal D because it's not a normal cornea. And the one on the lower right is endothelial dysfunction. Again, corneal edema, an abnormal cornea, but not specific for keratoconus. So kind of always remember, the bad is designed to separate normal from abnormal. Now, we use it often for keratoconus studies, but we use it with other parameters, like a final D greater than some number, but associated with posterior elevation. The next question is, well, why can't we just follow the parameters of the ABCD classification? Well, any classification is really designed more for population studies, not to follow a specific patient. And if you look at the example on the lower right, which is body mass index, you'll see if, let's say you had a BMI of 18.5 and went all the way up for 24.5, a huge increase, you would still be in the green range, no change in the staging. But if you went from 24.9 to 25, you would jump a whole stage. So staging or classifications are really designed, again, for population-based studies, but not to follow an individual patient. But we need to identify the individual patient. When that individual patient progresses, we also need to be able to identify true progression before changes in Kmax. If you think about it, Kmax, and I think everyone now in cross-linking and refractive surgery realizes that Kmax in itself is a very poor parameter. To have changes in Kmax means that you had further degradation of the anterior surface and usually further degradation of visual function. We also need to know when and if true progression occurs. But if we look at all the past prior parameters, and if you look at this long list, see if my pointer works. Is it yeah, it's showing up on the screen. Other than pachymetry, every single one of these parameters is an anterior surface parameter, which again means that you're going to have a change in visual function, visual performance, before you document progression. That's not what we really want. We want to be able to pick up disease early. We want to be able to know when and if the disease is changing as early as possible. Additionally, though we all think of Kmax as a quote, standard, none of these parameters have actually been validated. So all other than pachymetry are anterior surface parameters, and again, none of them have actually been validated. So we need to have a whole new look on how we determine when and if progression occurs. And as already alluded to, the reliance on Kmax 1 has led to visual loss, which we don't want to have prior to treat, and has delayed intervention. And again, as I said, Kmax is actually, though it's been used in FDA studies, has actually never been statistically validated. So why, again, a new progression display? Well, the ABCD progression display was designed specifically to follow and document progression of ectatic disease. It's based on one-sided confidence interval, one-sided because we're only interested if the cornea steepens or if it thins. It allows for documenting, which I'll show you examples later, of progression in spite of a stable anterior surface and or a stable Kmax. And it evaluates each anatomical layer individually and has been statistically validated. Well, the A and B parameters, again, A and B are anterior or posterior radius of curvature, taken from a 3 millimeter zone, not apically measured, but measured on the thinnest point of the cornea. These were new parameters when we first introduced it a number of years ago. So we didn't have noise measurements, so we needed to develop what the noise measurements were for each of these parameters. The C parameter was just thinnest corneal pachymetry, and we did previously had noise measurements for that. D is not an it's not a machine-generated parameter, but user-entered, so we don't do confidence intervals because, again, it's a user-operated distance visual acuity. And we also decided early on that it was important to look at both normal patients and patients with known keratoconus, because for your very young and very early disease, the noise measurements probably more closely mimic a normal population. We all know that the more advanced a disease gets, particularly a disease like keratoconus, the more inherent noisy measurements become. A very advanced disease is for almost any condition, measurements tend to be more noisy. So we looked at both, as I said, a normal population, because that would be appropriate for your younger patients with early disease, and a more established keratoconic database for your older patients with more established disease. And you don't need to know these numbers. They're, again, generated by the machine for you. But what we found is exactly what you would expect, and that is that the noise measurements in the keratoconic population were higher than the noise measurements in the normal. And again, we looked at both 95% and 80% one-sided confidence intervals for both the A parameter, the B parameter, and the C parameter. And this was the second release of the progression display. It would show you up to 8 exams over time, and it defaults to show you both the 80 and 95% confidence interval gaits for both the normal population in green and the keratic population in red. You'll also notice that, again, the gaits are obviously individually done for the A parameter, the B parameter, and the C parameter. Now, I suggest, just to make things less busy, that you determine clinically which database is more appropriate for yourself. The normal population, again, for young, early disease, or the keratoconic in red for the more established, and you can select which database you want to display. But again, the system will default to showing both, but it's a little bit easier to read if you actually select which one you're going to clinically use. This gives an example. This is a 16-year-old with progressive subclinical disease. And if you look on the far right, you'll see Kmax. At least in the US, we have to document, at least for now, a 1 diopter change. And you can see here, this is slightly under that 1 diopter gate that most people are currently using. But look at the A parameter. It's well past the 95% confidence interval, one that you would typically use in a 16-year-old, well past the 95% confidence interval on the B parameter and the C parameter. Documented very marked progressive disease in spite of the fact that it's less than 1 diopter change in Kmax. Again, Kmax is a late parameter that we really want to abandon the use of Kmax. Here's a 15-year-old with very early keratoconus with 13 months follow-up. And if you notice, there's 3 exams. Again, if you look at Kmax here on the right, it actually shows no change, or actually got a little bit better, but that's normal noise levels, but really no significant change. And that's because if you look at the anterior surface, it's been stable. But look what's going on in the back of the cornea. By the second exam, we're past the 80% confidence interval, and by the third exam, we're well past the 95%. This is when you want to intervene. You want to intervene when you've documented progression, but still have a stable anterior surface. You're going to preserve vision, not wait until vision actually deteriorates before you treat. And it's not just the early disease. This is a case of fairly progressive advanced keratoconus. If you look at the final D in this column, it's greater than 7. So we're not talking about early disease here. But again, if you look at the Kmax, 51.2, 52.1, 51.9, 50.3, actually no significant change. But again, if you look at the anterior surface, relatively stable. And here we're using the red gates because it's established keratoconus. But look by the fourth exam. We're past the 80% confidence interval on the B parameter and past the 95% confidence interval on the C parameter. So again, documented progressive disease in spite of a stable Kmax. So what have we shown? We've shown that there's a dissociation of clinical progression with changes in Kmax. We now have a tomographic-based classification system that again recognizes and measures all the anatomical layers. And we have a tomographic-based progression display that documents when there is statistically significant change. And normally what I use is any single parameter, and I'm going to kind of give you a little aside on that, that's at the 95% level, or any two parameters at the 80%. For those of you who can do the math, two parameters at 80% is basically the equivalent of one parameter at 95. With that, I will tell you that clinically, I take the C parameter with a little bit of a grain of salt. You know what taking something with a grain of salt means? It means I consider it, and the measurements were reliable, but like IOP, there's some diurnal variation in corneal thickness. And when we do noise measurements, we're doing it at the same time on the patient. So I just want you to take a grain of salt on the C parameter. If the only thing I saw was a change in the C parameter, I would still follow that patient. But the question really is then, well, how do we define progression after cross-linking? And currently, well, I say currently, prior to the most recent release of the new software, the gates were removed as soon as you showed a cross-linking treatment. And this this dotted line here represents a cross-linking treatment. If you look here on the bottom right, we've indicated when we've done a treatment, and you'll notice that all the gates are removed because those gates didn't apply after cross-linking. So we did a post-cross-linking progression study. Again, the goal was to measure the noise after cross-linking and to evaluate whether these measurements were reliable enough to serve as, again, a post-cross-linking progression display. We actually engaged two different facilities, the Elser Institute in Zurich and the Hamburg Keratoconus Center in Germany. And we initially did actually a study before this where we did relatively short-term, less than 1 year follow-up, and the noise measurements were so unreliable. So this was done on patients who were at least 12 months post-cross-linking. We used two sites basically to compare the two sites since cross-linking is a surgical procedure and there is some inherent variability between sites. We did 3 separate Pentacam measurements. We required at least 7.5 millimeters of coverage and an acceptable quality score. And similar to what we did before, we did pool variance and determined one-sided confidence intervals. We ended up looking at 60 eyes, 38 from Zurich and 22 from Hamburg. The average age was very similar between the two. The combined was 29.5. It was roughly 29.9 in Zurich and 28.8, so very similar in Hamburg. However, if you look at the time since cross-linking, the Zurich averaged 16.6 months and ranged anywhere from 12 months, which was our minimal, out to 28. But if you look at the Hamburg, the average was almost 4 years, 42.6, and ranged from 16 months to almost 10 years. And we will show you why that was important. And if we look at, again, you don't need to know these numbers, but interestingly, the noise measurements post-cross-linking fell actually in between the pre-op keratoconus and the normal population. And if you think about it, that makes at least a little bit of sense because if you take a keratoconic population and you somewhat normalize the surface, you should improve the noise measurements. And as it comes out, they fall in between, again, the normal population and the keratoconic population. We did then a geographic comparison between Zurich and Hamburg. The populations ended up having very similar ABC values and very similar noise measurements. The graph here is somewhat misleading because the N in Zurich is 38 and the N in Hamburg was 22. So these should be, I really should have a weighted average here, but the noise measurements were almost identical between the two. We then looked, because of the extreme length of time in the Hamburg, anywhere from 16 months all the way out to 10 years, we wanted to see if the noise measurements were stable over a long period of time. So we looked at 11 patients in Hamburg between 1 and 3 years, and 11 patients 3 to 10 years. And here it's a little bit easier to compare because the ends are identical, and you can see again graphically they're almost mirror images. So it appears that once you get past 12 months, and I already alluded to that we did a study earlier that prior to 12 months were too noisy, that appears that these measurements are very stable once you're one year out, all the way out to nearly 10 years. So this is what the new display looks like. It's been released now for a few months. For those of you who haven't updated, you should update your software. And if you look at it right now, it looks like we haven't changed much. And that's because these two exams after cross-linking are not yet 1 year out. And if your exams are less than a year, the gates will not appear. You can see on the bottom here, though, we have green for that normal population, red for the keratoconic, and now blue gates for post-cross-linking. So here is now an exam that has a number of exams after cross-linking. You'll see, let's see, I think there are 5 or 6 exams after cross-linking, and you'll notice the gates only appear on those that are at least 1 year out. Now, the display, as you can see from this example, tends to get very busy. There's something you can do to make it easier to interpret. Okay, here's that 16-year-old again showing everything, showing the red gates, the green gates, and the post-cross-linking gates. And again, it's a fairly busy-looking display. But again, in a 16-year-old, you can and should probably just select a green gate. So again, it looks a little bit less busy. However, after cross-linking, we're really only interested in the after cross-linking exams. And you can go to, on the upper left, where it says Select Exams, and you can select the exams of interest. In this case, we really want to look at the post-cross-linking exams. And you'll see here we've left one pre-op exam, the one right before cross-linking, and then all the post-cross-linking, and the map now becomes much easier to see. It's less busy, because this is now the area of regard. This is an example of a good response to cross-linking. You can see again a marked improvement in both the A, B, and C parameters, and again an example of a very good response to cross-linking. Here is an example of a potential retreatment. You'll notice here that on the A parameter we're above the 95%. On the B parameter there's some noise here, but here we're past the 80%, and the C parameter hasn't reached either of these. I would tell you again, if I'm going to retreat someone, I like to see at least 2 successive exams that are in agreement. But this is someone who I would at least follow more closely. And again, I can make it easier by just selecting the post-cross-linking, the same patient, but you can see how much easier it is to read the map. Again, we're only now looking at the post-cross-linking exams, because those are the exams that we're immediately interested in. So what have we shown? Well, the post-cross-linking measurements, variance, or noise can be used to determine progressive change after cross-linking. The noise measurements are consistent across different centers, actually just 2 centers, Zurich and Hamburg. The noise measurements seem very stable once you got past 12 months. And the new post-cross-linking confidence intervals have already been added to the most recent iteration of the ABCD progression display. But probably the most important slide is this, and that is independent validation of the progression display. There's been a few additional articles already out, But this one, the Belin ABCD progression display, identifies keratoconus progression earlier than conventional metrics was in the AJO in this year, and it stated it identified progression 4 to 7 months earlier than Kmax. This article in JCRS in 2021, evaluating keratoconus progression prior to crosslinking, maximum keratometry versus the ABC grade, and again, identified progression on an average 6 months earlier than Kmax. And then finally, in eye earlier this year, the ABCD progression display can assess keratoconus progression with high sensitivity and specificity. There's been a number of articles that have been subsequently published, but on average, the progression display seems to be able to identify patients at least 6 months earlier than Kmax. And again, the goal is to identify patients early, intervene before they've actually lost more vision. Thank you.